Hi everyone, this is APSC JCS 2020 Webinar 6. The session title is Present Advancement of Imaging. I'm Takashi Kubo from Wakayama, Japan, Chair. Co-chair David Quek is not available right now, so I'm only one chair. Today, we have 4 specialists of the imaging field. I'm looking forward to hearing very nice, elegant lecture from those specialists. Let's move to the next speaker. The next speaker is Dr. Son Jakan. He's coming from Asan Medical Center, University of Ulsan College of Medicine, Korea. His title is New Techniques of Echocardiography. Please, Dr. Son.
Okay, thank you very much for kind introduction. It's my great honor to take part in this notable event, APSC JCS webinar. My title today is New Techniques of Echocardiography. I have no conflict of interest for this presentation. We have witnessed the successful clinical introduction of various echocardiographic techniques, and also for the past 2 decades, we have witnessed the dramatic improvement in various radiologic images in cardiology field. For the next 15 minutes, I'd like to focus on evolution of echo techniques and how they contribute to the understanding of clinical diseases in our routine clinical practice. I believe that everybody agrees that the main contribution of echo Doppler technique is that we can estimate the pressure non-invasively. So in patient aortic stenosis, for evaluation of severity, we used to use invasive cardiac catheterization. However, nowadays, echo technique almost replaced invasive cardiac catheterization. And many established guidelines, they use valve area, peak velocity, and mean gradient for estimation of AS severity. For mitral stenosis, echo Doppler technique also provides accurate estimation of severity, almost replacing invasive catheterization. Well, how about the mitral regurgitation? In the past, LV angiography, the usual imaging, the only imaging modality used for evaluation of mitral regurgitation. However, we don't have any information about the etiology of mitral regurgitation. However, using echo, it is very easy to differentiate rheumatic versus mitral valve prolapse. In patients with mitral valve prolapse, localization of prolapsing segment is very important. And if we use modified two-chamber views, eccentricity of Z can provide valuable information for patient care. So this is a typical example of various prolapsing segments which can be easily localized using non-invasive echo Doppler technique. The next contribution of Doppler technique is now it widely opened the new era of diastology. In conventional color Doppler echo, we used frequency shift induced by blood flow, red blood cells. However, in tissue Doppler imaging, we use frequency shift induced by left ventricular wall, which contributes significantly to understand diastology. So mitral inflow during diastole, we can easily measure E and A velocity. And using tissue Doppler imaging, we also use the movement of mitral annulus, and we can calculate the E prime and A prime velocities. This is very important because it can provide effective and accurate way to estimate the LV filling pressure. So E velocity is parallel with the increase of LV filling pressure and also increase in relaxation velocity. The relaxation velocity can be estimated E prime. So LV filling pressure is easily anticipated to have a parallel relationship with the E of E prime, and is well evaluated in the clinical situations. Moreover, using TRZ velocity, we can calculate the pulmonary artery pressure, which is very important variable associated with the prognosis of various cardiovascular diseases. So comprehensive evaluation of all pressure profiles in cardiac chambers can be done non-invasively. The second important contribution of echo Doppler technique was possible using harmonic image and TE with improved resolution. The left side, using TT, we are not so sure whether this patient has vegetation. However, using TE with a higher frequency, we can easily diagnose vegetation aortic valve. This is well demonstrated again in patients with prosthesis, and actually echo criteria has been successfully implemented as a diagnostic criteria for patients with suspected infective endocarditis. Another case shows hypertrophic cardiomyopathy and SAM and septal contact. However, in these patients, LVOT obstruction occurs different mechanism. There is no SAM, but hypertrophic muscle inserts directly into the anterior mitral leaflet, causing LV outflow tract obstruction. So if you compare SAM and in the other cases, you can see thick papillary muscle with the basal caudal attachment induces LV outflow tract obstruction. So although hypertrophic cardiomyopathy is characterized by thickened myocardium, its pathology is not confined to myocardium. Mitral valve and papillary muscle and subvalvular structure should be evaluated comprehensively because a different LVOT obstruction mechanism may work. Let me show you another cases. This is a side-by-side showing SAM and anomalous insertion of papillary muscle to mitral valve. And this is an elongated papillary muscle with a caudal attachment. Accurate visualization of different mechanisms is critical for surgeons to prepare successful surgical outcomes. This is another case of HCM with the LVOT obstruction. You can easily see the SAM and septal contact. However, in this panel, you can see some echogenic linear structure in LV outflow tract. Transesophageal echo clearly shows this patient has also subaortic membrane. So the LVOT obstruction, we may see ASH and SAM. In addition to this common pathology, in this particular cases, subaortic membrane also contributes to LVOT obstruction. So using improved resolution, harmonic image and TE contributed significantly to document pathophysiology mechanism of various hemodynamic changes. The third important contribution is we can understand the myocardial mechanics, specifically longitudinal shortening using tissue Doppler imaging. So for Doppler diastology, we focused on E prime, A prime, but if we focus on this systolic velocity, we can estimate different velocity profiles in the myocardium. So in this diagram, we can easily understand that the basal part of a myocardium, the velocity is higher than that in the apex. And the the longitudinal shortening, it can cause the shortening of a whole myocardium. So using tissue Doppler velocity imaging, we can measure velocity gradient. Actually, we can measure the degree of deformity. So usually, longitudinal shortening, we may obtain negative values in strain. How can you use this in clinical practice? I will show you the two clinical cases using apical wall motion abnormality, typical apical aneurysm. This is a reduced ejection pressure left bundle branch block. If we use a strain velocity and strain image, we can clearly see this patient apex contracts. However, in this apical aneurysm, the apex cannot have active contraction, and these two strain images can clearly demonstrate between normal post-systole shortening in LVBB versus pathologic lengthening in patient with apical aneurysm. The problem of the time velocity based imaging is that it is extremely noisy, especially in the apical area. With a slight movement of region of interest, we can obtain three different velocity profiles. And the angle dependence is the critical limitation of this tissue velocity imaging. Now, as MRI did, we use a speckle tracking imaging. We are not using Doppler tracing, but as a fingerprint, we can trace a speckle with a higher resolution. Let me show the frame-by-frame image of one speckle during systole and during diastole. So computer technology improves significantly, and echo can check these movements and calculate the strain and deformation. So compared to tissue velocity imaging, 2D strain speckle tracking imaging, we don't have to worry about the angle dependency. Let me show this representative image. This green line is the actual movement, which can be measured by 2D strain speckle tracking. However, in the conventional tissue velocity imaging, the velocity component perpendicular to the parallel to the Doppler signals can only be measured. This is the problem. So we can overcome the angle dependency using 2D strain speckle tracking, and also we can use a radial strain. So in clinical practice, we can usually move a strain image in routine practice. And if we evaluate the strain pattern, we can specifically diagnose cardiac amyloidosis. And in patients with the thickened myocardium, although ejection fraction is well preserved, we can clearly see decreased contractility in hypertrophied septum. More importantly, compared to LV ejection fraction, the conventional indices representing LV systole function, longitudinal deformation changes much earlier than the LV ejection fraction does. So it is quite well accepted. Ejection fraction is another good prognostic marker in patients with heart failure. However, global longitudinal strain, it contributes significantly to predict higher risk patient, so it can be easily implemented in routine clinical practice. The next step is we can understand more closely how the myocardium or left ventricle works. More than almost several hundred years ago, myocardial contraction is well demonstrated that wringing of a linen cloth to squeeze out the water. So apical rotation is a very important component to maintain LV systole function. However, till this time, we don't know how to evaluate it. However, if we use speckle tracking imaging, we can easily calculate apical rotation, and we can use this index to represent LV systole function. So this is an apical counterclockwise rotation. This is a basal clockwise rotation. In both conditions, we can easily measure. So rotation, twist, and torsion, these indices can be easily measured using new echo technique. Nowadays, left atrial function can be evaluated using 2D spectral tracking, and it provides important prognostic implications. This is a very complicated slide showing how complicated the diastolic function evolves. Every index may have a U-shaped changes. However, if we measure LA strain, this shows a very gradual changes, which might have a more powerful prognosis factor, which I think for the next decade, we will focus on how to evaluate the LA strain, how to implement these indices in routine clinical practice. The next area is a three-dimensional echo. Specifically, right side heart is a very complicated structure, and we cannot use simple 2D geometric assumption for evaluation these chambers. However, nowadays, 3D approach can provide accurate numbers and measures to evaluate the RV function. More importantly, tricuspid valve can be evaluated very easily using transthoracic 3D echo. So this is the only way to evaluate in vivo 3D structure of tricuspid. In 2D conventional echo, we usually use tomographic view, which is not accurate. The next is the flow. It is not well covered, but using the cardiac looping, vortex occurs. This is a very effective way for circulation. It is well established. But how to evaluate this vorticity? Using, this is a conventional echo. And this is a contrast echo using BBI. So we can evaluate the vorticity, and harmonic analysis provides several factors, and we can have a new area how to evaluate this vorticity. The other area is the regurgitation. It is not well established, but nowadays we believe that conventional penal assumption is not good. All shape should be implemented in this flow calculation, and several new programs is trying to approach this way for accurate calculation of flow. This is my last two slides showing the future directions. Augmented or virtual reality is widely used, but the other areas is we are trying to have minimize small ultrasound. AI is now approaching very rapidly. For calculation or measurement, it is quite acceptable. But recently, FDA accepted AI-guided ultrasound acquisition, which might change the whole paradigm of our belief in routine clinical practice. This is my conclusion slide. Okay, rapid evolution in technology has provided a new environment for clinicians. However, appropriate selection of new imaging modalities still remains an elusive and challenging issue. The more important issue is how to educate next generation cardiac imaging specialists using all these programs. Thank you very much for your attention.
Thank you very much, Dr. Song. So any questions? So I have questions. So Dr. Song, diastolic function.
Okay.
There are many technologies to evaluate the cardiac function. What is the most promising technologies or index for evaluating the diastolic function?
So at this moment, we cannot have any sound conclusion, but personally, I believe the E over E prime is still working very well in many different clinical situations. So that's the most important variable, I believe. But as I mentioned, the LA strain is approaching very rapidly. So we may have a different or different new indices incorporating multiple numbers in near future.
Mhm. So next question is HFpEF, heart failure preserved
Yeah.
EF.
Yeah.
So in the HFpEF, what is the most useful technologies in echocardiography, and what is the most useful predictor associated with a future patient outcome?
Oh, it's a quite challenging question. Actually, we need a longitudinal outcome data in big cohort, but LA strain is quite attractive because we know the LV systole function evaluated by routine echo studies. Ejection fraction is not predicted by much, but global longitudinal strain with the LA strain may improve the how to handle all these patients. The real challenging issue is there is no specific medication to change the natural history of these patients have heart failure with preserved LV ejection fraction. So we should also focus on how to manage these patients, how to follow up these patients. So two areas should have some positive results, and I would say the LA strain and the global longitudinal strain is two most promising indices at this moment.
So final question. Sorry, wait a minute. Okay. Question from audience.
Okay.
I have a question, doctor. What is the best strain by 2D echo or strain by 3D echo, and why? Number two, how to measure strain in non-sinus patients, for example, atrial fibrillation patients.
So the second question, atrial fibrillation, there is no answer. Okay. So atrial fibrillation itself represents the patient has some problems. Okay. 2D versus 3D, oh, it's quite challenging. But 3D, I think the technique should improve significantly. Still, it has some problems in terms of noise and the measurement variability and the standardization. But 2D, it is well standardized. Although some paper shows there is some difference depending on the machines we use, but the trend, if you use the same machine, 2D strain is quite reliable. And compared to LV ejection fraction, measurement variability is less. So at this moment, 2D has a more strong advantage, but the technique changes, improves very significantly. I don't know, within 10 years, 3D or 4D method, definitely, theoretically, 3D and 4D should be better, but at this moment, it has some problems.
Thank you very much. Time is coming. So, okay, and let's move to the next. Next is Dr. Makoto Orii from Morioka, Japan. He will talk about the advance in CTCA. Please go ahead.
Thank you. Thank you, Dr. Kubo. I'll prepare the presentation slide now. Okay, so thank you, Dr. Kubo, and thank you also, Professor Akasaka, my big boss in Wakayama. Hi, everyone. I'm Makoto Orii from Department of Radiology, Iwate Medical University. Now I worked as radiologist, especially in cardiac imaging. It's a great honor for me to have a presentation about the advance in CT coronary angiogram, CTCA. I have no COI to disclose. Okay, let me start my presentation. In the background, which will you use invasive coronary angiography, CAZ, or CTCA in the future for the evaluation of coronary artery disease? This data from the annual report of Japanese registry about the number of cases of CAG and CTCA. Since 2010, the number of CAG were around 500,000. while the number of CTCA has increased every year, exceeding the number of CAG for the first time in 2018. The number of CTCA cases is expected to increase further in Japan. So with this background, I would like to talk about 3 topics today. First, update of CTCA equipment. Second, update of image reconstruction of CTCA. First 2 topics is technical side. And finally, I would like to describe what is expected of the CTCA in the future and what we are doing now in the light of a new situation. So in the update of CT equipment, I'd like to introduce ultra-high resolution, UHR technologies. In the upper row, you can see the lung carcinoma, temporal bone, and pancreatic neuroendocrine tumor using the conventional CT scan. If you can use UHR CT, the margin of the lung tumor and bone are more clearly seen than in the conventional scan. You can see the microcyst in tumor. This is more clearly shown with UHR CT imaging. UHR CT acquires data with a 0.25 millimeter slice compared with a 0.5 millimeter slice of conventional CT. The UHR detector is also newly designed to provide more than twice the spatial resolution compared with conventional CT technology. This slide shows the CTCA images of 25, 50, and 75% stenosis in the phantom model. You can see the overestimation in conventional CT, especially in the moderate and severe stenosis due to the blooming artifact. This overestimation in moderate and severe stenosis has been the cause of high false positive compared with CAG. CTCA with UHR can reduce blooming artifact and provide accurate assessment of coronary stenosis. In our data, CTCA with UHR had high sensitivity and negative predictive value, same as in past reports. Moreover, CTCA with UHR had a high positive predictive value compared with the past reports because of the improvement of image quality. Previous studies that quantified coronary artery stenosis using CTCA have shown relatively high limits of agreement for CAG. Even though the high-end 320 low CTCA, the range for limits of agreement was plus or minus 24%. Our narrower range for the limits of agreement, plus or minus 16%, suggests that using CTCA with UHR can allow us to obtain CT images with a high spatial resolution and enable accurate quantification of coronary artery stenosis. This slide shows the CTCA images of everolimus eluting stent with 3.5 millimeter. Compared to a conventional CTCA, you can see the stent strut and neointima in stent lumen more clearly in UHR CTCA images. CTCA is not feasible for the evaluation of stents with diameter below 3.0 meter. But CTCA with ultra-high resolution could assess the 80% of in-stent lumen with diameter 2.5. Also in our data, you can see the stent in LAD and diagonal branch. UHRCT could assess in-stent lumen in diagonal branch stent with 2.25 millimeter without blooming artifact. So in case with peripheral artery disease, subtraction CTA using UHR can visualize the significant stenosis in left common iliac artery, occlusion of left superficial femoral artery with good collateral vessels. You can also see clearly below the knee arteries and assess the status of distal runoff. Subtraction CTA using UHR could also visualize the plantar and dorsal pedis arteries on the both foot. This information could be useful in patients with critical limb ischemia because the status of distal runoff is important before amputation. Okay, next, I'd like to talk regarding the update of imaging reconstruction of CTCA. During the latest years, artificial intelligence, AI, and especially machine learning have experienced a growth in popularity. In fact, machine learning allows the efficient handling of big volume of data, allowing to tackle issues that were unfeasible before, especially with deep learning, which utilize multi-layered neural networks. Deep learning-based reconstruction, DLR, is a new technique for image quality improvement. DLR is trained to differentiate signal from noise so that algorithm can suppress noise while enhancing signal. Because it is trained with advanced model-based iterative reconstruction, MBIR, it exhibits high spatial resolution. This slide shows the overview of DLR process. DLR learns to differentiate signal from noise by training on select high-quality patient data sets acquired with high tube current and reconstructed with all the benefits of state-of-the-art MBIR, not possibly clinically. Clinically, this training process is in a factory. Because this time-consuming training process is completed before leaving the factory, fully trained DLR is able to work quickly in the hospital. These slides show a case of stable angina. You can see plaque and moderate stenosis in the proximal LAD in the conventional reconstruction CTCA image. DLR image could significantly reduce the noise while maintaining high spatial resolution in artery. As a result, the plaque in LAD is visualized more clearly compared with conventional reconstruction. So this is summary. DLR enables improved spatial resolution with significantly reduced noise. The right side is conventional and the DLR is right side. High noise reduction performance in low contrast regions and granularity allow improvement image quality with low dose scanning. Okay, let's move to further perspective. I would like to describe what is expected of CTCA in the future and what we are doing now in the light of a new situation. This slide shows the number of CT and MRI machines per million population in G20 member countries. Japan has the largest number of CT and MRI in the world. In addition, Japan has the highest number of CT images per population, surpassing the United States. With these backgrounds, the number of CTCA cases is also expected to increase further. Iwate Medical University, our university, is located in Iwate Prefecture. Iwate Prefecture is located northern part of Japan. You can get Morioka, which is the capital and largest city, in 2 hours from Tokyo. Iwate Prefecture is the second largest in Japan, however, only has a population of 1.2 million. This means that we need to cover a large medical area with small number of doctors. The medical area in Iwate Prefecture is formed mainly with 19 prefecture hospitals. Most of the prefecture hospitals have CT, and about half of these hospitals can take CTCA. However, the protocol and image quality are obviously different in each hospital. CT equipment and the technology of image reconstruction, as I said, will continue to update at university hospital. But the patients living in local area are not able to benefit from the new technology. With also the worldwide pandemic of COVID-19, there is a need to establish network that patients can take a high quality CTCA without the burden of mobility. Our institution has more than 20 years experience of CTCA, so we have just started for the new project of standardization of CTCA protocol. Sorry, we only have a Japanese version now, but CTCA using a shared protocol will start in our medical region. If we can have some same quality CTCA images in each hospital, the goal of this project will develop the application of automatic detection and classification of stenosis using AI. CTFFR is another application in which AI plays an important role. FFR CT is now available in Japan, but the problem is that the number of available countries and facilities is limited. On-site FFR in this slide, in each CT vendors can give the functional information of coronary artery stenosis in each hospital if they can take a high quality CTCA images. This slide shows a summary of my presentation. Complete agreement of percent diameter stenosis between CTCA and CAZ is challenging, but CTCA using ultra high resolution could reduce blooming artifacts and improve image quality. Deep learning reconstruction could also improve in image quality. Brand new network is needed for high quality CTCA in each hospital and for patients without the burden of mobility. Thank you everyone for your attention. This is the conclusion slide of my presentation. The title of Patrick Seroy's presentation in JCS 2020 is Coronary CT Angiography will replace invasive angiography. The CTCA must further evolve for the new era to come. Thank you.
Thank you very much, Dr. Orii. So, open for discussion. Any questions or comments? So, Dr. Orii?
Yep.
So CTCA is a very wonderful technology.
Mhm.
But my question is, what is a limitation? What effort is needed? What improvement is needed to spread this technology to our daily clinical practice?
Yes, that's a good question. So I introduced the two technologies. One is CT equipment and one is reconstruction. And the equipment side, ultra high resolution CT has a lot of limitations. UHR CT is helical scan and with low time resolution. Therefore, heart rate should be under 16 without any arrhythmia such as premature supraventricular contraction, PVC, and atrial fibrillation. Also, in our experience, we cannot use conventional reconstruction if heart rate is over 55. Moreover, reconstruction time is over 1 hour. This is time consuming. Another issue of UHR CTCA is increased image noise due to the reduced voxel size. Image noise will be increased if body weight is over 17 kilograms. The patient should be diet. Body mass index is over 28. On the side of reconstruction, I show a very clear plaque in the proximal region. But deep learning construction, this is some limitation. Why the spatial resolution in peripheral region is relatively low. And another limitation in deep learning is strong artifact in peripheral region and artifact due to calcified plaque. Because this plaque is emphasized using this new technique. So further update of this new technology is needed for the evaluation of peripheral disease and calcified plaque.
I have one question regarding CT improvement. So there is no free lunch in life. What is the radiation dose in addition to have a higher resolution? Do you need more radiation?
Yes, exactly. So, but if you can use deep learning reconstruction, the radiation dose will be decreased.
Okay.
But if you use ultra high resolution, as you said, we need more radiation dose. This is a problem.
Okay, I have a question from audience, but time is coming, so I'm so sorry. Let's move to the next presenter. Thank you very much, Dr. Orii. So next is Dr. Calvin Chin Loong from Singapore National Heart Center. He will talk about advances in cardiac MR. Please, go ahead.
Thank you so much for the very kind invitation from APSC and JCS. Today I'm going to talk a little bit about the advances of cardiac MRI. So this slide just basically shows some of the common applications of cardiac MRI. But if you were to think about the applications, it can perhaps be broadly classified into 3 different areas, looking at cardiac function, LV mass, some form of characterization of the myocardium, and assessment of myocardial ischemia. So as we know, cardiac MRI is very accurate in assessing cardiac volumes and mass because you can basically divide the whole heart into fixed slices, a defined number of slices. And if you were to contour the endocardium, the inside volume, in diastole and systole, and you take the difference between the two, you can derive stroke volumes and ejection fraction from that. Using the same approach, if you were to contour the outside volume minus by the inside volume, you get myocardium volume. And if you were to multiply that by the specific gravity of 1.05, we can get LV mass. So this is something that we do typically by a fellow or even a consultant on a regular basis to look at cardiac function and masses. But you can imagine this takes a long time to analyze. So in the age of artificial intelligence, machine learning has improved the workflow of post-processing. And there are actually many algorithms out there. Some are available as products that you can use. This is a video that I picked up from Circle Cardiovascular Imaging, or CVI-42. Basically, it can automatically detect your contours on the endocardium and the epicardium with a click, and you can derive your volumes and your masses that way. So extending these machine algorithms, we are now able to combine large imaging data sets with a click of a mouse. And this illustrates an atlas model based on 1,000 individuals without cardiac diseases. Basically, what it's trying to show is that males have got increased concentricity compared to females. And these areas actually correspond to regions of increased wall stress. The whole analysis of auto segmentation and the atlas building took almost 2 days compared to the number of man hours it would take if you were to do this manually. In the next area, I'm going to talk a little bit about tissue characterization. Perhaps one of the unparalleled strengths of CMR is its ability to characterize tissues with the use of gadolinium contrast, specifically in the area of diagnosing fibrosis. And you can see the areas where the extracellular space are expanded due to fibrosis in this instance. Gadolinium will accumulate in extracellular space, and it will light up bright relative to the surrounding black or normal regions. But there is a limitation, right? It works very well in some disease process like myocardial infarction, where the dead cells are able to completely replaced by collagen, and it will light up very bright. And this is very obvious that you can see a patient with almost a near transmural infarction. However, we're beginning to appreciate the significance of the shades of gray. This represents areas of more diffuse type of fibrosis, which potentially could be treatment targets. But these regions are less obvious, and quantification of these regions is extremely challenging. So there are mapping techniques available, such as T1 mapping, that has been developed to overcome some of these limitations. We're now able to quantify the signal intensity in these regions that are used to estimate the amount of fibrosis in the heart. And these techniques have actually been validated with fibrosis based on histology. So what is the potential use of ECV mapping or T1 mapping? Just want to quickly highlight this using a patient. This is a patient with aortic stenosis, no symptoms at baseline, with a Vmax of 4.9. Mass is increased, and based on the ECV, which is a measure that we use to assess extracellular volume, it's expanded, elevated at 30.3%. You could actually use the myocardium volume along with the ECV to derive the fibrosis volume, which is about 36 mils per meter square. 1 year at follow-up, develop more symptoms, mass have increased along with ECV and the fibrosis volume. At that point, because of the symptoms, we suggested going for an aortic valve replacement. We managed to call him back for a repeat scan, and you can see improvement in all the indices. Mass have reduced, ECV has remained almost similar, but the fibrosis volume in this case have gone down from 59 down to almost 40. So the potential of this mapping technique is you can now use to follow progression of disease and perhaps treatment response as well. Added to that fact, there are also increasingly more and more publications out to show that the amount of expansion, extracellular expansion, is associated with worse prognosis compared to those with normal myocardium. But if you have got replacement fibrosis, which is thought to be irreversible, your prognosis is the worst compared to the previous two groups. The last part, I'm going to spend a little bit more time to talk about the diagnosis of coronary artery disease. We use that quite a bit in stress MRI. This is just a quick summary to show that, the diagnosis of coronary artery disease can be broadly divided in two groups. One is to induce hyperemia, and most of the time we use vasodilating agents. The other is to induce ischemia from oxygen supply demand mismatch. Most of the time we use some form of stress test or dobutamine. You can use different imaging tools to detect perfusion defects, regional wall motion, or even ECG changes. Just to broadly highlight that in MRI, actually it has got the strength or the theoretical benefits of detecting both perfusion defects as well as regional wall motion abnormalities. But most of the time we use MRI to detect perfusion defects. Not very often do we use dobutamine to look for a regional wall with MRI. Again, this is the perfusion scan that we do with adenosine stress. You could probably appreciate hypoperfusion in the LAD territory, extending from the base to the mid and all the way down to the apex of the heart, suggesting that there's a significant ischemia in the LAD territory. But we are all aware of the advantages of exercise stress. There's a more physiological way to induce ischemia. And moreover, there are other additional benefits of doing exercise stress. The parameters can provide possible incremental prognostic values, such as heart rate recovery, METs, and Duke score. So in fact, in some centers, exercise treadmill has been used with cardiac MRI. And this is a video that's taken from the OSU, Ohio State University in the US, where this is an MRI compatible treadmill. The patient exercised to peak exercise, subsequently transferred quickly across to the MRI scanner for scanning. And recently in our heart center in Singapore, we have developed a supine bike exercise stress protocol, where now your exercise stress machine or your supine ergometer is attached to the end of the MRI scanner. The benefits of doing this is that we minimize transfer time from the treadmill across to the MRI scanner. And what is the other added benefit is that now you're able to image the heart at every stage of the exercise. I'm just going to let the video run a little bit. That's how we prepare the patient. We strap them down. And then the patient cycles in it. And then we're able to scan the heart at every stage of stress. We start them at 25 watts, and then we will increase 25 watts every 3 minutes until the point where the patient is not able to exercise anymore because of fatigue or because of symptoms. So what is the potential benefit of doing an exercise stress? I would like to highlight with a patient case. This is a 57-year-old male, has got a history of smoking, hyperlipidemia, and high blood pressure, has got chest pain with exertion. Kind of show the exercise stress protocol that we use. Just to highlight that we are doing both perfusion imaging at peak exercise. And right after that, we will do a short axis slices that you will see at peak exercise. So we are capturing both perfusion as well as regional wall motion abnormalities. And we'll do our late get after stress perfusion is completed. On the left, you can see images that are taken at rest. Perhaps you may be able to appreciate some regional wall motion abnormalities already at rest in the inferior lateral walls. Just at stage 2, at 50 watts of cycling, you can appreciate that the regional wall in the inferior as well as inferior lateral is a lot more obvious. So these images are taken as the patient is cycling at real time, and the patient is still breathing at that point, no holding of breath. So he has got regional wall motion abnormalities. What about perfusion defects? Again, at peak exercise, 50 watts, you may be able to appreciate perfusion defects in the inferior and inferior lateral walls, both base and mid, as well as apical slices. And true enough, with late gadolinium enhancement imaging, you can see a subendocardial infarction in the inferior wall extending all the way from the base to near the apical inferior segments. The last thing that we did for this patient is that we are able to calculate or assess the exercise capacity of this patient. You can look at the base, rest-based CMR measurements are largely normal, but with exercise, he can only manage a peak of 6.6 liters per minute per meter square. We actually have got normal ranges published a couple of years ago at JCMR, and 6.6 liters actually is associated with about 6th percentile for his age and sex. So it's very low for him. Underwent invasive coronary angiogram, and true enough, he has got 2 lesions quite tight in RCA, as well as a lesion in the LAD territory. So he has got double vessel disease in this patient. So in summary, I think advances in MR technology and imaging sequences have right now expanded the indications of MRI, and it has also helped to improve the workflow of post-processing, taken a lot of the manual contouring that we do, as highlighted in this talk. It also helps us to develop more sensitive measures that potentially can be useful to monitor disease progression and guide therapies in some of these patients. With this, I'd like to thank you for your attention and happy to take any questions at this point.
Thank you very much. Nice lecture, Dr. Kadi. So any questions? I believe Dr. Orii, he's a specialist of the MRI also. So
Yep.
I believe you have a question to him. So please go ahead, Dr. Orii.
Yep. Oh, sorry, Dr. Kubo, could you say again? So what, I need to do one more question.
Yeah, any question to him?
Ah, I see. So, yes, what is the benefit of exercise test? The resolution, time resolution or spatial resolution is much more lower in the exercise test. What is the benefit? I mean, in the echocardiography, we can do the same test. So, yeah, my question is, what is the benefit?
So I think that's a very important question. So there are actually several benefits. One benefit is, of course, you're doing something that's physiological stress.
Mm-hmm.
In echo, conventionally, we look at regional wall motion abnormalities, although there are some studies that also suggest that you could look at perfusion defects with echo stress. But with exercise stress, potentially you have got 4 different parameters you can look at. You can look at perfusion defects, regional wall motion abnormalities, late get, viability, and also the 4th thing that we talked about is exercise capacity. So our belief is that, you know, if you're looking at multi-parametric exercise stress CMR, it may potentially have incremental benefits in detecting areas of ischemia that sometimes you may not be able to do that with just one single parameter.
Thank you.
I also have a question about the ischemic test, perfusion image. It's a very quick question. So do you use a contrast or not?
Yes, we use contrast for perfusion. So we use 0.075 for stress, and at rest we use the same 0.075. So it's actually a 1.5, 0.15 dose.
And I have one more question. And so what is the advantage of MR angiography compared to the CTCA?
Yeah, so I think there are advantages of MR coronary angiogram is obviously that you're not exposing the patients to radiation. We tend to do that in the young group of patients looking for anomalous coronary artery. In terms of looking for stenosis, depending on the patient population, we would sometimes prefer doing a CT angiogram over doing an MR coronary angiogram. But I must say that, you know, with improvement in techniques, MR techniques, the resolution, spatial resolutions is improving. But I think there's still a lot of studies out there to compare the two.
Any questions? One more. I have a very niche question. So high intensity plaque of coronary artery. So what is a high intensity plaque of coronary artery wall in MRI? It is considered to be the vulnerable plaque. What is the pathology and what is the mechanism of high intensity?
The answer is that we don't really know for sure. We know that it is associated with vulnerable plaques, and we know that vulnerable plaques are not stable and they tend to break off. But in terms of the physics behind it, I'm not very familiar with that as well. Yeah.
Thank you so much. Okay, any questions? Speakers, audience? Okay, thank you very much. Nice lecture. Thank you, everyone. So it's time to closing remarks. This session, we will hear about the present advancement of imaging from 4 specialists. And hopefully, this advancement, development of the imaging is directly associated with patient outcome improvement. Thank you for your cooperation. I would like to close this session. Thank you.